Thank you so much. Good evening, ladies and gentlemen. We thank you so much for joining us in yet another interesting exploration of the topic of anxiety disorders. Yesterday, we had the pleasure of listening and learning from Dr. Katama. And today, before he starts off, I would like to give a recap of what happened yesterday. So we started off by Dr. Katama informing us about a number of things, among which was the fact that anxiety actually lies on a spectrum. He taught us that anxiety is a normal part of life, but it becomes a disorder when worry or fear is too much, lasts too long, and starts interfering with work, school, or relationships. He also taught us that anxiety disorders generally share a similar pattern where they involve intense and persistent fear, body symptoms such as tension or restlessness, and avoidance of things or places that trigger the anxiety. Then we learned that diagnostic systems are now actually more flexible. For example, panic attacks can occur in any anxiety disorder, and agoraphobia and panic disorder are now actually treated as separate, but sometimes also overlapping conditions. Then we got to appreciate that culture actually shapes how anxiety is shown. The way we express anxiety in the Ugandan context may not necessarily be the way it is expressed in other contexts. Some people may talk of it as thinking too much, olowooza nnyo. Others may say, I am feeling on edge. He also talked about wind attacks. Locally, within the Ugandan context, we have terms like okwelarikirira, worrying a lot, which can be translated into several Ugandan languages. We also noted that we actually have good tools that can help us to make the diagnosis of anxiety disorders clearer. So we have interviews and rating scales such as the Mini, GAD-7, and HAM-A, which can help identify anxiety, and tools such as the Sheehan Disability Scale or the WHO-DAS show how much this anxiety is affecting the life of the person who has it. We also appreciated something we often tend to ignore, that anxiety disorders are very common. They affect millions and they often begin before the age of 20. We also noted that they are more common among women, and specific phobias, social anxiety, and panic disorders are the most common types. And it was interesting to note that anxiety doesn't like standing alone most of the time. It often occurs together with other conditions such as depression, substance use, or medical illnesses. And when it is combined with depression, the symptoms are actually more severe, and the risk of suicide within this person increases a lot. And he closed by emphasizing something important, that we need to always check for other possible causes of the anxiety. Conditions such as thyroid disease, heart problems, epilepsy, PTSD, or drug and alcohol use can actually mimic anxiety. And therefore, he emphasized that careful assessment can actually help us to make a right diagnosis and a solid treatment plan. Dr. Katama, for that, we thank you, and we look forward to what you have to present today. Ladies and gentlemen, along the course of the discussion, in case you have any question, please feel free to post it within our chat. Dr. Katama, Sadat, over to you. Take us away. Thank you.
Thank you, Dr. Miyanga, for that wonderful recap and introduction. You've really summarized whatever you had to throw in at the beginning while kicking off with today's discussion. So today we are going to look at the neurobiology, what exactly happens in the brain to lead to this thing called fear, worry, anxiety. What exactly happens to lead to this? And that is what I'll be discussing for most part of today. Now, I'll start by just showing some of these, this pictorial of the brain. And specifically, I want attention to be drawn to structures like the amygdala, the hippocampus, and this medial prefrontal cortex, because these will feature a lot in whatever we shall be discussing today. So all the things you're going to see, whether avoidance, someone freezing, fleeing, or fighting in response to a threatening situation, all of that is basically going to depend on the interconnections between some of the structures and other structures that we will see. Yesterday we mentioned how fear is an emotional response to a threat. The threat might be real or perceived. And then the anxiety is the anticipation of a threat in the future. And today we want to understand what exactly goes on to lead to these emotions. Right from the beginning of this series, we have always talked about nature versus nurture, the role of genetics, epigenetics, the interaction between the environment and the genes of an individual. We've always talked about the sex differences in some of these conditions. And today I'm going to pay some attention to nurture, especially when it comes to stress. And then, of course, the socioeconomic factors. I'll show us how things that can happen in the person's early childhood can actually lead to the inception of anxiety feelings within an individual later on in life. So when you look at acute stress, chronic, whether persistent, we shall talk about the cumulative effect of different factors that we shall be considering. Here I have this quote. It was from the Lancet in 2021. And it says that when people are exposed to stressors, such as public speaking, scary pictures, or painful stimulation, basically, studies have reported increased stress responses in those individuals with anxiety disorders compared with controls. So someone with an anxiety disorder will definitely be more stressed if they have to be in a particular situation that posits about their anxiety. So these are a result of differences in the peripheral, in the autonomic nervous conduction, neurochemical, hormonal measures, as well as the startle response. And so we shall be looking at the relevancy of all these. Particularly, I want us to draw attention to this childhood adversity and anxiety disorders. Many of us are parents, many of us will be parents, many of us have been children, and we've probably gone through some of these things. Or we have inflicted some of these things on others through bullying and other things. Now, this study looked at 2,981 people who had a childhood trauma. And this study concluded an association between that childhood trauma and poorer life outcomes. So things like poor somatic health. People can develop these things like metabolic syndrome, diabetes, they can develop things like hypertension based on what they actually went through. Then, of course, brain changes. I mentioned these things here, the medial prefrontal cortex and the amygdala, and we are going to pay much attention to this. But we find that in individuals who have had early childhood trauma, all of these things can actually happen in these individuals, dysregulation of stress systems. So you find the cortisol levels are out of balance, they will have these maladaptive personality traits. And because of this, there is an increased vulnerability of these individuals actually develop anxiety disorders, and affective disorders like depression. In this study, it looked at the cumulative risk, basically based on the different childhood adverse events an individual faced. They looked at the risk of developing anxiety. And when you look at this curve, you find that with increasing cumulative adversity, the anxiety levels also increased. This was similar to even the levels of depression in this study. Now, there is the independent contribution and the additive contribution. Let's say someone had just low father affection. You'll find that they lie on this curve, but at a lower point in terms of anxiety. But when you combine low father affection, you add mother's depression, and maybe you add physical abuse, then they will move along this curve towards higher levels of anxiety. So that is the additive effect, whereby when you find more adversity events happening in the same individual, chances of having the anxiety actually kind of increased. And that is what this study looked at. I want us to review some of these things because in dealing with management, we shall use some of these, especially when we are dealing with CBT in terms of the psychological management. So learning theories, we get most of what we experience, we tend to learn most of the things that we experience through different mechanisms. There can be habituation. Here, someone basically, the innate responses diminish over time with repeated stimulus. We talked about, yesterday, we talked about a child having to cry because the mother has disappeared from their vicinity. But over time, as this child grows, this actually tends to wear off. So the person will know that, oh, the mom has gone to the market. She will come back. So the person actually no longer cries because of the mother disappearing from their vicinity. Then the classical conditioning, which is familiar to many of us, Ivan Pavlov and the bell in dogs, where there is a conditioned stimulus and an unconditioned stimulus, and then how these can stimulate a response in an organism. In operant conditioning, basically here we are dealing with behavior changing based on either punishment or reward. So it is that simple. A child does something good, you praise them. If the child starts standing and walking, people will sing for the child and clap, and the child will actually continue walking. Then if they do something wrong, then they reprimand, then they are punished. That is under operant conditioning. And then we have, of course, complex learning. And there are other forms of learning, things like social learning, affective learning, and others. I specifically look at this classical conditioning because of its association with what we are going to see, especially when we are looking at the fear response and the extinction of fears. So Pavlov did this experiment, and he found that when you associate a conditioned stimulus, that is a stimulus that is neutral, like a bell. If you ring a bell to a dog, it might not respond. But if you associate that bell with something else, like providing a bone or a meat piece, you ring a bell, then you provide a meat piece. Initially, the meat piece will actually make the dog salivate because once it sees something to eat, it will salivate. But later on, the dog will start associating the bell sound with the meat piece, so that when the bell rings, even when the meat piece is not produced, there will be salivation. That is the classical conditioning form of learning. This is going to come in handy because the way fear comes about, the way what comes about, is basically entirely comes from the perceived threat. Something happens, it might not be significant enough to cause fear over an individual. But because of the other thing that might be associated with it or something else that happens, the next time that thing, that particular stimulus happens, like you would see a bell, it will actually start fear in an individual. So there is an acquisition of this response. Basically, the learning happens. You combine the conditioned stimulus and the unconditioned stimulus, and then there is learning, and the conditioned response actually increases. So that over time, as you ring the bell, and the dog will salivate. However, should you stop providing the meat piece and you only ring the bell, over time, the dog will learn to know that even if the bell rings, the meat piece does not come. So this conditioned response will go away, that salivation will stop. I'll be explaining this later on as we look at the brain systems that I have mentioned. So it is important to note how these systems actually do work. But then the memory stays there. It does not completely go away. So there can be a spontaneous recovery of the conditioned stimulus. Should it happen that something that probably will associate that stimulus with a meat piece, it might not be a meat piece, but something else can actually easily trigger the response to the bell sound. So that is what happens in conditioned, in this form of learning. Now, threat conditioning and anxiety, they have a very close mechanism. You find that the anxiety might arise because of the fear response stimulus in an individual. Something happens, maybe someone witnesses something, as you can see, as it can happen in PTSD, or someone was walking and then someone was bitten by a snake. The next time they are walking and they find something by maybe a rope or something by the road, and it's probably at night and there is a moonlight and they see it, they will definitely jump. It is because of the association between the other event that happened and this threat that is here. Not that this is actually a snake, but there is that association between what happened the previous time and the current time. However, with repeated non-exposure to that stimulus, or if someone learns that this thing is actually not harmful, there is fear extinction. And that is what we are looking at in terms of threat conditioning. So the threat can be conditioned, it can be initiated in someone. This is basically the brain of a rodent, and it just shows the connections between different brain parts that play a role in the networks that play a role in initiating fear response. And like I said, we shall pay close attention to the medial prefrontal cortex, things like the amygdala, the hippocampus, and other brain parts. This is what basically I've been talking about. So you'll find things like neuroimaging showing the changes that can happen. And then when you do other functional studies, you're going to find a disturbance or a change in the chemical transmissions within the brains of individuals or organisms that have anxiety-like traits. Several neuropeptides, neurotransmitters have been implicated in anxiety disorders, and these actually form the basis for our management. So we find things like corticotropin releasing factor in the HPA axis. This one plays a very significant role, and we are going to see this shortly. But all these other things actually play a role in initiating the fears. Then the neurotransmitters like serotonin, glutamate, then GABA, they will play the significant roles based on their activities in those specific brain regions where they are released from and to. So the GABA, like we said, is the major inhibitory neurotransmitter of the brain. And then serotonin will be relevant in the connections between some of these other brain parts. Here I have this image that I will use this and the next image to explain all the science that I'm basically talking about. And after this, the rest will be just going through a couple other things. So what you see here, I said we shall pay attention to the amygdala, the hippocampus. Now from this is the hypothalamus, this is the paraventricular nucleus of the hypothalamus, which releases the corticotropin releasing hormone to the pituitary. And then the pituitary will release the adrenocorticotropic hormone to the adrenal cortex. Then the adrenal cortex releases cortisol. And we know the effects of cortisol as far as fear is concerned. So cortisol basically will ensure that there is enough glucose in the blood so that there is a preparation for any response, whether fight or flight. Now, this cortisol here has negative feedback effect on the hypothalamus and the pituitary. So it inhibits its own release in case the release is too much. However, it activates the hippocampus. And this hippocampus has its projections to the paraventricular nucleus of the hypothalamus, which is inhibitory. But it can also have projections to the amygdala, as we shall see. The amygdala here is the brain part that actually processes emotions and then fear and then the response. So it is one that creates the memory for the response that has come from outside. It receives the sensory input and then interprets it and creates a fear response. That fear response will be modulated through structures like the hypothalamus and then leading to this event. So for it, it actually activates the paraventricular nucleus of the hypothalamus. This amygdala is also receives projections from the areas like the locus coeruleus. And you're going to find that the locus coeruleus basically has predominantly norepinephrine, and we shall see where you can actually use the norepinephrine, the selective norepinephrine reuptake inhibitors in management of these anxiety disorders because of the role this norepinephrine plays in activating the amygdala and the hypothalamus. Then there is the raphe nucleus. I've been talking about serotonin, 5-HT serotonin. So the raphe nucleus releases serotonin in controlling this hypothalamus. So all this that we are talking about and what will form the basis for our medications, our choice of medications in the different anxiety disorders will be based on this image here. However, that is not all. This is now the role of the amygdala. Like I said, fear conditioning is basically brought about by the amygdala. So it has different parts. It has the lateral amygdala, and then there is this central amygdala. And then it receives projections from the hippocampus, from the ventromedial, prefrontal cortex, like I've said, it receives from the thalamus and other brain parts. Now, when there is no fear stimulus from the environment, there will be no fear response. So the amygdala will just be there waiting for whatever is going on to activate it. So what happens is that the amygdala will receive, now this is the fear conditioning, it will receive input from the hippocampus, from the thalamus, from the prefrontal cortex, where it will then process this fear. Because of the threat from the environment or the threat that is perceived, this amygdala is going to create a fear response and it will remember this stimulus so that the next time it happens, there is an easier response to it. And this activation is through glutamate. However, should it be that this fearful experience that happened probably is through learning, an individual copes with it and realizes that, oh, if I see a rope, it is just a rope and it's not a snake. The individual over time associate the rope with no danger. As a result, the input from the hippocampus, the thalamus, the prefrontal cortex about the rope being a threat will change to it being a no threat. And as a result, the amygdala is going to cut off the response, the fear response, through release of GABA to the central amygdala. So that is what we call fear extinction. It will cut off that response to that fear because it is no longer a threat. However, so in that case, there will be no fear response. However, the memory will remain there so that in case something else, it will not be a rope this time, but it will be something similar. It will easily make the response, the fear response, come back very fast, and that will be this renewal of the fear response. So this is basically what happens in instigating fear within an individual. And this will be forming the basis for our choice of medications. When someone is overly worried, if you give a benzodiazepine, you find that actually they will calm down. If someone is overly worried or has this anxiety and give them an SSRI, you realize that over time, it actually settles them. Now, tomorrow we shall be looking at the role of those medications, and then we shall explain why in the initial days of starting, for example, SSRI treatment or SNRI treatment, there is some kind of anxiety that will first increase in an individual before actually it wears off and the symptoms are controlled. And we shall discuss this tomorrow. So we are doing all this so that we understand that we need to always assess our patients. So we know what exactly goes on in these individuals to lead to some of these symptoms that they come with. Now, anxiety, yesterday we were talking about the definitions and then the prevalence, the epidemiology of that. There is a very high likelihood of a heritability of anxiety. You'll find that for a family member with an anxiety disorder, another family member developing an anxiety disorder will be up to 6 times those individuals. And then in screening studies, you find up to 40% heritability, which means it is always necessary to ask for the family history of these mental conditions so that you know whether this is something genetic you're dealing with or probably some other environmental thing that is actually contributing to this. So whether panic disorder, generalized anxiety disorder, or the phobias, all of these, they tend to aggregate in families because of this increased irritability. This study just looked at the different genes that are usually associated with anxiety disorders. I'm really not going to talk much about them, but you find that different anxiety questionnaires that were used, then there will be the genes and the association and p-values to look at the statistical significance of those. Then Dr. Myanga has given us a recap of yesterday, and he mentioned about the comorbidity, the co-occurrence of anxiety disorders with other conditions. These might be physical conditions, these might be other mental disorders. So there is because of a shared genetic risk, it is when someone has, for example, depression, it is easy for them to actually get anxiety because of a shared risk within the genes. When you look at the genes that we mentioned here, and then you can look at the genes that we mentioned under things like depression, when we're looking at bipolar, when we looked at schizophrenia, you're going to actually find some genes that are cross-cutting in these conditions. And so this shows us the importance of studying and treating anxiety disorders in the wider physical context. It not only the mental disorders, but also in physical conditions. Someone will come with pain, and then before you know it, they have features of anxiety. And even other things like we said yesterday, we talked about the differential diagnosis of anxiety disorders. Epigenetics, this one can't go unmentioned, like I said in the beginning. The role of the environment and then switching on the genes within an individual. The genes will be there, but if something doesn't happen from the environment to actually trigger a change in these genes to switch on the enzymes and other processes within the body, someone might actually not experience the symptoms. But the interplay between the environment and then the genes will lead to gene expression, leading to an increased response, cellular response. Then this will lead to increased signaling in the same brain paths we've talked about. So basically, this is what will then lead to these anxiety symptoms manifesting as a result of the environment. So here you will look at this table. It will show you the different switches that happen, like methylation of the different genes, and then what will happen afterwards. So you'll find in panic disorder and other anxiety disorders. Right from the beginning, we have always talked about the gut microbiome, whether anxiety, whether depression, whether schizophrenia, and other conditions. So this study looked at the composition of the gut microbiome in people with anxiety disorders. And you find that these individuals actually had lower quantities of these bacteria. Quite often, people these days take antibiotics irrationally. Someone comes with a headache to a clinic or to a pharmacy and they say, I want amoxicillin. And you ask them, why are you taking it? I have a headache. They don't know what this is actually going to do to their normal flora within the body. And then these have actually been shown that with lower quantities of these species of bacteria, we can actually have some of these disorders come about. And now research is looking into how to use this knowledge to actually manage patients. How to use this knowledge. So these species will lead to production of short-chain fatty acids, and then there will be a connection. Of course, there is always a bidirectional relationship between the brain and then the gut. And then what happens between this side? Things might come from the gut and find their way to the brain, which might actually be damaging to the brain. And so we need to always pay attention to this. Research now has gone to such lower levels. Well, for us, we are still looking at that. We are still doing research from the large perspective, from the ambiguous perspective, but we need to now go down into these lower levels and understand in our context, because these are things that have been done mostly for the other countries, but then in our setting, how do we change this narrative? This one, interoception, basically we are looking at the connection between the self-awareness and then anxiety. So you'll find that when managing anxiety with cognitive behavioral therapies, we shall talk about things like breathing exercises and how to use them in calming an individual down. So this will also come because of the relationship between the different brain parts and the connections that we have talked about. So definitions have come for interoception about this self-awareness, and it is important for someone to know, now I'm in this state, this thing is likely to happen, I should do this, so that they cope with that situation. Of course, I have talked about these, the symptoms, how then they can actually affect anxiety-like behavior. If someone was walking normal and then maybe something pricked in the bushes, the heart rate will immediately go up. So for someone who has ever had a panic attack, once the heart rate goes up, they will immediately start thinking, I'm going to die. and then this starts worry. So the first worry is about the heart rate has gone up. Then this will build up a second worry about the first worry. And then it will lead to that cycle whereby someone actually also hyperventilating. Some actually will end up losing consciousness. The same thing happens if it is a tachycardia that has been induced actually. Find that if you induce a tachycardia in an individual, it can actually induce a panic attack based on the mechanisms that we have talked about. Yes, sex differences do occur in the risk of anxiety. Yesterday we said that anxiety is more common in females, and this comes right from the differences in the hormonal compositions, the fluctuations, the hormonal fluctuations within women, and then of course handling the stress from the environment itself, the degree to which we all respond to stress is actually different, and it is worse for women. A lot is expected of women even in society, and this actually can contribute to how they perceive or interpret the threats in their lives. Then of course the brain structure and function as well. This is in anxiety, it was also featured in depression. Those are changes. This slide here looks at heritability of anxiety in terms of sex difference. Let's say if a father only has anxiety, what are the chances that the child will have anxiety if it is a male or if it's a female? And if it is only the mother and if it is both. So you find that all throughout, the chances of having anxiety are more for the females than for the males. However, should both parents have anxiety, then the chances of having anxiety are higher for males, for the male offspring, compared to the female offspring. It's always necessary that we assess and manage these conditions, because it is not only affecting the individual who has the condition, it can actually go down to others. And that's the relevance of putting this slide in this presentation. Then, of course, the biomarkers, basically these ones are coming from what we've been looking at. Either you do the genetic and the genetic biomarkers. Neuroimaging may not have shown conclusive results, but still it is necessary to rule out other possible causes. And then, of course, we have to do physiological assays. We need to be sure that whatever we are dealing with is not a physical illness. Yesterday, we talked about things like hyperthyroidism, how it can present with typical features of anxiety. So we need to make sure that we do the physiological assays and rule out all possible physical causes of the symptoms. In summary, we said that anxiety disorders are the most common group of mental disorders. And for them, they are characterized by excessive fear and anxiety. The risk, of course, is because of the nature interacting with the environment, and then the different brain circuits that happen to lead to the behavior and the emotional experiences that individuals get. We need to pay close attention to childhood adversity. Let's take good care of the kids, because if we put them under particular stress, this stress is actually going to build up, and it will then lead to these disorders in adult life. We talked about depression, and even now it features in anxiety. And then it is necessary to always do structural and functional imaging studies to understand what exactly is going on. Like I said, heritability is very likely, and even comorbidity with other disorders is highly likely. Thank you for listening. Yes, Dr. Myanga.
Oh, wow. Thank you so much. Thank you, admin. Thank you so much, Dr. Katama. Discussions to do with the neurobiology are never easy. We thank you for having made it as easy to understand as possible. We would like to thank our friends. I'm seeing we have friends from Ghana, from Kenya, who have joined this discussion. It's wonderful to know that people across the globe are interested in mental health. That is the way to go. Would also like to thank our seniors who have joined this discussion. Whenever you are seen in the chat, we have a sense of security and know that if any hard question arises, we can always bounce it to you. Dr. Vilabwa, we thank you so much for always joining us. And we thank you, Dr. Hilary Rimaso, the president of the Uganda Association of Psychiatrists, for also joining us. At this moment, before we dive into the questions, we would like to get special insights from Dr. Hilary Rimaso, the president of the Uganda Association of Psychiatrists, in relation to the current topic. When we were still his students, he used to tell us a lot about anxiety, and he used to always emphasize the reality that anxiety is much more common than most of the conditions we talk about. Dr. Hilary Rimaso, please kindly unmute yourself and share the insights you have garnered over the years with us. Dr. Irimaso, is everything okay? In case you are somehow muted, kindly just type in the chat and we shall do what we can. I see you are unmuted currently. All right. So maybe as Dr. Irimaso, he seems to be having some technical issue as he's sorting whatever may be happening. Dr. Katama, we have quite a question here from Musa Mohammed Mahmoud. By the way, Dr. Musa, we thank you so much for always joining us in these discussions, and we thank you for the insightful questions you always give us. It's a pleasure. Dr. Irimaso, are you now able to talk?
I have been talking. Can you hear me now?
Yes, we can hear you. We are happy to hear you. Please take us away.
Very good. Thank you for the invitation to speak on this topic. You and Dr. Sadat have dissected the neurobiology very succinctly and befitting of your status as a psychiatrist. It's good that you mentioned our interactions, our clinical interactions before when you're still in training, and I'm glad that you took up the gospel according to how it is written. And here you are dissecting it. I'm also happy to see the seniors, Dr. Birawa Okecho, thank you for attending. And I would like to acknowledge Dr. Donna Kavatesi. Dr. Donna Kavatesi was a childhood hero. From the time we used to hear about her on radio, teaching us about sexual and reproductive health, and Dr. Donna is also a family friend. Thank you. You are welcome, Dr. Donna. Your son is here as a content expert here. So, going on, I am again extremely happy that you dissected the topic as it should be. From what you said, I used to emphasize the importance of diagnosing anxiety disorders in your everyday primary care. I'm again happy to see that most of the attendees actually non-psychiatrists, as I know them. Some are medical doctors, medical officers, or other specialties. And I used to tell you 40–50% of patients in primary health care actually do present with anxiety disorders. Unfortunately, they are not diagnosed. But even when they are seen to have an anxiety element, most doctors other than psychiatrists actually downplay the effect of anxiety. Even when identified, rarely do they give it the attention that it deserves. But today, and probably yesterday, you have seen that this is not a mere a social issue, but it has a biological basis to it. And once we continue this trend of disseminating our science to all stakeholders, then the diagnosis and the identification of these disorders will be easier to identify, but also manage accordingly. So I am extremely happy. As you said, anxiety disorders are very, very common. Some texts indicate at about 30%. A systematic study in Uganda a few years ago pointed at about 23%. But you can see that anxiety disorders in the general population ranges from 20 to almost 40, 50%, depending on the clinical setting. However, if you look at the DSM-5 criterion, right from the topic anxiety disorders, you will see from depressive disorders, you'll come down to anxiety disorders, obsessive and compulsive disorders previously were part of anxiety disorders. You'll come and to trauma and stress-related disorders. All that is anxiety. They all used to be in anxiety. Then dissociative disorders have a significant element of anxiety. Then you come to a significant topic that most medical officers usually find: somatic symptom and related disorders. Then you come to feeding and eating disorders, elimination disorders, sleep-wake disorders, sexual dysfunctions, gender dysphoria, and maybe in children, disruptive impulse control and conduct disorders. Many of these have an element of anxiety. Therefore, anxiety disorders are not only limited to its topic of anxiety disorders, but cuts across. Actually, I always say it forms almost half of the DSM-5 criterion. When you come to substance and related disorders, then you always find that most of people who use substances actually are coping or finding coping mechanisms. And then when you miss the point, then you don't get the right diagnosis and you keep getting relapses for these substances. Then comes to our point: is it actually a 22% or 30%? Because when you do a systematic review of all these disorders that have anxiety disorders as an element, you will find that they possibly cut across 50, 60% of all mental illnesses. Unfortunately, we focus on the conditions that present with 1%. Schizophrenia and psychotic spectrum disorders, bipolar affective disorders, depression. Well, depression is not 1%, it's a bit more, 15, 20%, but you'll find that anxiety disorders are very, very common. I'm looking forward to tomorrow when you talk about the symptomatology and treatment. I'm definitely looking forward to that. And once the participants have actually understood that patients who present with anxiety, it is not like they are weak in mind. It is not that you can snap out of it. It's not that they are making it changeable. As most point, you see, once we take these conditions seriously, and you have brought out to the science very well. I didn't attend the session yesterday, but I trust you based on our prior interactions. You will find that anxiety disorders are very, very common. Actually, even in bipolar disorders, you'll find that the prodromal symptoms are usually anxiety disorders. They go untreated, they go unmanaged, then it progresses into full-blown bipolar disorders. Actually, even depression, people usually start with anxiety symptoms. And when at a certain point you have diagnosed a certain illness, then you go back on the continuum. As you always say, all mental illnesses are on a continuum. Usually anxiety disorders in adults is usually the P illness that you'll find. So whatever you reach and then you don't manage the anxiety, the underlying anxiety, you miss the point. And actually, I am very happy that we have very many medical personnel who are not actually psychiatrists, but are very interested. That is where we want to direct our attention that anxiety disorders are very common. They are often missed either by us specialists or actually in the primary health care settings. And eventually patients struggle. By the time they reach us for proper diagnosis and proper management, it has probably worsened. Therefore, here, this is almost like an eye-opener for most of the mental health workers in this aspect of anxiety disorders. All other mental illnesses are important, but anxiety disorders, where the prevalence is about 30% in the general population, we treat less than 1%. If you go to general psychiatric centers, actually rarely do you find the diagnosis of anxiety disorders. Where do they go? How do they present? Do we miss the diagnosis just because we don't know the presentation, or we downplay the significance of these symptoms? So you again, during our clinical rotation, you saw that when we followed up patients, you find that at the end of it all, we either start with the anxiety or end up with anxiety. And once you manage that, then the patient has complete resolution. To the psychiatrist, if you have diagnosed the patient, you give medication or other interventions, and the patient is not responding, just remember, you may not have fully diagnosed everything. Until you rule out anxiety disorders, then you might not be able to effectively manage the patient. And what we do require is always complete symptom resolution, and we can achieve that. I'm looking definitely forward for the presentation tomorrow about the clinical signs and symptoms, and then treatment. And hopefully it will also meet our expectations as the last 2 days have.
Wow. Dr. Irimaso.
Yes.
We thank you so much for those words of wisdom you have shared. Whoever dropped off before you started sharing has missed a lot. Those are insights that we don't find every day. We are left with just 6 minutes to the end of the session, and we wanted to the presenter to respond to just a few questions in the chat before we close at exactly 8 p.m. But we thank you so much, and we wish you could actually rejoin us tomorrow and share more of your experience and more of your insights, please. Dr. Katama, Sadat,
Yes,
you
please.
have a number of questions, and our colleague, Dr. Mose Muhammad, has said, thank you so much for the clear and insightful explanation of the neurobiology of anxiety disorders. I would like to ask, what specific changes in brain structure, neurotransmitters, and the stress response system are involved in causing anxiety disorders? And how can understanding these biological mechanisms help in developing better treatment approaches? Please take over.
Yes, thank you, Muhammad, for that question. So when we're looking at the neurobiology, the brain structures that I mentioned, I said that the amygdala is the major structure within the brain that actually modulates fear. And in anxiety disorders, this amygdala is in the overdrive. It is working so much, and it heightens the fear and then the threat detection. That is what I mentioned earlier. But of course, because of the inputs from these other parts of the brain, like the hippocampus. Now, the hippocampus basically has the connection to the amygdala, instructing it whether to respond to a particular threat or to downsize on the response. So if in anxiety disorders, you find that the hippocampus might actually not be working very well. It might be smaller, it might be less active, which is going to lead to the amygdala just functioning on the fear response that is already within it, and yet it has to be a regulator. Then, of course, I mentioned about the prefrontal cortex, and this one also, its control over the amygdala will be weaker in these situations of anxiety. That is for the brain structure. When you look at the neurotransmitters, and this one now continues to the next part of the question, looking at the biological mechanisms to develop the treatment approaches. So these neurotransmitters, serotonin is basically concerned with mood regulation, but also emotional regulation. Then GABA, we said GABA is the major inhibitory neurotransmitter of the brain. And if this GABA in the amygdala, for example, is not functioning appropriately, then you're going to actually find that the glutamate neurons will be firing too much, and then the amygdala will go and overdrive. So when we are targeting the management, we're going to target these neurotransmitter systems. Norepinephrine, this one is concerned with hyperarousal and then the physical symptoms that actually the individual present with, the palpitations, the sweating. It works through the alpha and beta adrenergic receptors, and those are some of the symptoms that the individuals will present with. And so targeting that, and then we shall look at the role of things like beta blockers in management of some anxiety states. So that is to do with the neurotransmitters. So I hope this question answers the question of the neurotransmitters, the brain structure, as well as the biological mechanisms to deal with, to get better treatment approaches. Thank you.
Thank you so much, Dr. Katama. That is actually a whole tutorial on its own, but you have ably summarized it. Abonyo Kandi Lydia has said, thanks for the presentation here from Uganda. I would like to know how the gut is related to anxiety. I did get it well. So as we are summarizing, I think I can quickly run you, Kandi, through that. So the gut and brain, according to what I picked from Dr. Katama, are deeply connected through what we call the gut-brain axis. And this is mainly via the vagus nerve, hormones, and immune signals. And gut bacteria actually help to produce key mood neurochemicals such as serotonin, which we know has a very large role to play in mood disorders such as depression and even anxiety itself. And 90% of serotonin actually comes from the gut. So when this balance is disturbed, whether by stress or poor diet or infection, it can actually trigger inflammation, okay, overactivate brain stress circuits and worsen anxiety overall. So you supporting your gut health through good nutrition, probiotics, and stress control can actually help reduce anxiety symptoms. Ladies and gentlemen, we have only 1 minute left. We would like to thank you so much for having joined us. Tomorrow, we are diving into the treatment principles of anxiety disorders, and you do not want to miss that. Same link, same time. We thank you so much for having joined us. Allow us to wish you a lovely and restful evening and night. Thank you.